So, the important topic we are going to discuss today is about the hypersplenism and splenomegaly. Now, the question arises, what is the basic difference between hypersplenism and splenomegaly? So, if it's only the diffuse enlargement of the spleen, it is called as splenomegaly. But when there is hyperfunctioning of the spleen, and because there is a lot of destruction of we know that actually the spleen is the most important part of the reticuloendothelial system. So all the megakaryocytes and the platelets and the RBCs, they actually come all the way to the spleen, and they are actually metabolized there, which is a part of the reticular endothelial system. So actually, whenever the spleen is not only enlarged, but also because it's a hyperfunctioning as well, and the patient also develops some kind of symptoms related to the bone marrow, aplasia particularly, and there is thrombocytopenia, there's anemia, like there's neutropenia, and there's anemia as well, or the white blood cell count is also low, and as a result of that there is somehow in some conditions there is a reactive hyperplasia of the bone marrow. Then that particular condition is called as hypersplenism. So talking about the little bit about the anatomy, we all know that it's actually located in the left hypochondrium, and we all know that spleen is actually occupying the space which is approximately to the level of 9th and the 10th rib. Plus, it's covered by the some kind of a splenic fracture, which is related to that. We've got a important notch of the spleen as well, which is called as the splenic notch, and the splenic hilum, in which the different vessels like the splenic vein and the splenic artery, they get actually entry into the spleen and responsible for the blood supply of the spleen. We all know that actually the splenic artery is coming from the celiac artery, and multiple short gastric arteries, they're also arising from the splenic artery. And we know that actually the splenic vein actually combines with the superior mesenteric vein, and they combine together to form a portal vein, which is actually a part of the portosystemic circulation. So remember, the important landmarks is 9th and 10th rib, and it's occupying the left hypochondrium. And the important thing is like the trauma or blast explosion or gunshot injuries, which are involving the abdomen and causing direct or indirect blunt or penetrating injury to the abdomen, and particularly involving the left hypochondrium. There's a tendency that there would be trauma to the spleen. So important is like we should know about the different important causes of the hypersplenism. So actually there are infective causes, there are metabolic causes, there are neoplastic causes. We will be discussing these causes one by one. So talking about the infective causes, we actually divide bacterial and the viral and the parasitic infections. The important thing, if we talk about the bacterial causes for hypersplenism, the typhoid and the paratyphoid, we know that the bacterial species, which is called as a Salmonella typhi and Salmonella paratyphi, they're actually important to cause a medical condition which is called as enteric fever, or you can say typhoid fever. So the patient actually present to you with a high grade fever, which is actually the step-ladder fever, and loose motion and all the symptoms related to the gastroenteritis. So in the first week, the patient is actually complaining of the vague abdominal pain and the vomiting and a high-grade fever, which is gradually building up, which is called as a step-ladder fever. And in the second week, the patient may actually present to you with the rose spots, and the patient can have anemia as well. And if you talk about the symptoms of the third week, the patient can actually develop the splenomegaly. So one of the causes for hypersplenism, or you can say the splenomegaly, is a bacterial infection, which is a typhoid and the paratyphoid. And initially it was considered, if we talk about the making a diagnosis for the typhoid fever, we got some important tests like the typhidode, in which we test about the antibodies like IgG antibodies and IgM antibodies. And we all know that IgM antibodies, they are meant for the acute infections. And if we talk about the chronic infections, the IgG antibodies would be elevated, but in case of the acute infections, IgM antibodies would be elevated. Other than the antibodies, like which we call as a typhidode test, there's another important test which is called as a Vidal test, and it actually measures the value of, or you can say the number of the organisms or the salmonella typhi or paratyphi which are present in the blood, or they're present in the stool. So Vidal is actually measuring the cutoff value, which is about 300. But the most sensitive test for the diagnosis of this, typhoid or typhoid fever, you can also call it enteric fever, because most of the time it's involving the intestines, and especially ileum, and the terminal ileum, most importantly, is involved if we talk about the enteric perforations later on, which is a kind of a complication of the enteric fever. So the blood cultures are the diagnostic test, or you can say the gold standard test, because Vidal and the typhidode test, they can be give you kind of a false positive result. So it's important you go for this, or either you go for the PCR testing, which is actually the qualitative and the quantitative testing of the number of the organisms, active organisms, which are in the body. So if a patient has developed the typhoid fever, and if we talk about a prolonged condition, or maybe he is having such kind of infection for greater than 2 weeks, then the patient can actually present to you with a splenomegaly. The other cause is the typhus, and another important cause for this is the tuberculosis, and especially abdominal TB. The Mycobacterium tuberculosis is not related to the abdomen, but it's also involving the chest, which is called a pulmonary TB, and it can also involve the bones, which is called as the spinal, or you can call it spine TB. And if there's involvement of the gut and small intestine and large intestine especially, they call this abdominal TB. So if we talk about the abdominal TB, so there can be a reactive kind of a splenomegaly in case of the tuberculosis. And if you could appreciate this, is if you could see, you can see the miliary TB as well, or if you could, this is the enlarged liver, and this is the spleen. So if you could actually see that there are some kind of the homogeneous, kind of a pacification which are present in the spleen, and that's, this is a particular picture of the splenic tuberculosis. So if we talk about some other causes, like the bacterial causes, then is psittacosis is one of the causes for the splenomegaly, and septicemia, because actually when the patient is in septicemia, there's a chance that the patient will go into a DIC, which is disseminated intravascular coagulopathy, and there's a lot of disruption of the platelets, and because of this auto destruction, there is kind of a hyper-functioning of the spleen, because all these megakaryocytes and the platelets and the RBCs, they all together come to the spleen, and because of the over-functioning of the spleen, there can be splenic enlargement, or there can be a kind of a splenic abscess. So if we talk about the causes behind the development of the splenic abscess, there can be infective splenic embolus, there can be typhoid, there can be paratyphoid fever, some kinds, or you can say complicated osteomyelitis, that can also develop a splenic abscess, iritis media or puerperal sepsis. All these conditions can actually lead to the development of the splenic abscess. And these splenic abscesses actually can result in the diffuse or, more localized enlargement of the spleen. As you could appreciate in the CT, liver is normal in architecture, and you can see the portal, the bile duct and the portal vein, they're actually normal in the caliber. But if you could see, you can see the two homogeneous opacities here, and there are hypodense lesions which are present in the upper part of the spleen, which is indicating as actually the patient would be febrile, and if he's tender and there's a left hypochondrial pain and there's a splenic enlargement as well, then you can think about the splenic abscess as well. Then that was a bacterial group, and there's another group which is called a spirochaetal group. In the infective, we talk about the infective causes. So whale disease or syphilis is one of the causes, talking about the viral infections. They can be infectious mononucleases, HIV related thrombocytopenia, and some kind of the protozoal and parasitic infections like the malaria and like the schistosomiasis. Okay, so talking about the infective causes for splenomegaly or hypersplenism, we actually divide in 4 important categories: bacterial, spirochaetal, viral, and parasitic and protozoal. So the bacterial actually, the causes for bacterial, the typhoid, the paratyphoid, the tuberculosis, the septicemia, the splenic abscess. And talking about the spirochaetal infections, whale disease or syphilis. And in case of the viral infection, there's the infectious mononucleases and HIV-related thrombocytopenia. And one of the most important causes for splenomegaly is malaria and schistosomiasis. So we all know that actually the most common is like malaria, and we check for the ICT for malaria parasites, and the patient present to you with the shivering and the chills and fever with rigors and chills, and it can be sometimes when it's associated with the abscess as well, the patient can present with a high fever, but generally the patient present with a low-grade persistent fever associated with rigors and chills. And in TB, there would be night sweats. And schistosomiasis, the organism behind this would be obviously the Schistosoma mannsoni and Schistosoma paratracheum. So these actually important organisms which can cause diffuse the viral infections and all the symptoms of the viral infections, and they can actually cause the splenomegaly as well. Trypanosomiasis is one of the other cause for the development of the splenomegaly, and Calazar, so all leishmaniasis can be. But if we talk about the massive enlargement of the spleen, so in fact, remember, infectious mononucleasis, schistosomiasis, and leishmaniasis, these are, or some myeloproliferative disorders, they can actually lead to the massive enlargement of the spleen, or they can be hydatid disease, or you can say hydatid cyst, or they can be tropical splenomegaly as well. Now, that was the infective group, which was not only involving the bacterial, but protozoal, parasitic, and viral infection as well. Now, if we talk about some kind of blood diseases, so we actually divide this into the leukemias and myeloproliferative disorders and Polycythemia Vera and anemias. So, talking about the acute leukemia there is another condition which is idiopathic, or you can say immune thrombocytopenic purpura. And if we talk about the idiopathic thrombocytopenic purpura, so it's actually ITP is a kind of the autoimmune disorder. And in this autoimmune disorder, actually, if we talk about the membrane of the platelets, so actually the membrane of these platelets is, some formed by the glycoprotein. And actually the IgG autoantibodies, they are formed as a process of the autoimmunity, and they actually try to target the platelets. Now, the patient can present to you with the low platelet count, and then you try to, investigate such a case with the bone marrow examination. So, if the bone marrow comes out to be normal, then you will think about the idiopathic thrombocytopenic purpura. And if the bone marrow is hypocellular, then you will think about, think about the aplastic anemias. And if the bone marrow comes out to be hypercellular, then you would be thinking about the, leukemias and myelofibrotic processes. So you can say that idiopathic thrombocytopenic purpura is a kind of the autoimmune process in which the platelets, membrane, glycoprotein, they're being targeted by the glycoprotein IgG autoantibodies. They actually try to target the platelets, and the process of the megakaryocytes formation is normal within the bone marrow, but once they come into the periphery, or you can say they come into the general circulation, there's a kind of the targeting antibodies which are circulating all around the body, and they try to target the platelets. And because of the excessive destruction of the platelets, there would be splenomegaly, because all this would be coming to the reticular endothelial system, and that would be coming to the spleen, and there would be a splenomegaly and hypersplenism. Plus, you should always think about that if the platelet count is less than 60, then and the bone marrow comes out to be normal, and there's a low platelet count just, and the the white blood counts and the anemia, or the RBC or hemoglobin level comes out to be normal, then you think about the idiopathic thrombocytopenic purpura. And obviously, in such cases where it's a ITP, can be a case in which the childhood ITP, in which the patient actually present to you within the 5 years of the age. It's a kind of the early presentation, and obviously the signs and symptoms would remain the same, but and there would be kind of the purpura, or there would be petechial hemorrhages, the purpura and the petechial hemorrhages on the skin and the mucous membrane of the body. And there would be, in case of the adult females, there can be excessive menorrhagia, or there would be kind of excessive bleeding from anywhere after the dental surgery, minor bruise, especially in case of the adults. So if we talk about the age group for the adult idiopathic thrombocytopenic purpura, then that ranges between 15 to 50 years, and most common in the females. In talking about the children, the age would be 5 years. And the patient will present to you with all these symptoms of, petechial hemorrhages or purpura or bruising after a viral infection, and that can be a throat infection, or that can be a respiratory infection, and the patient will then be presenting to you with these symptoms, and the presentation would be short, like 2 months. So the acute conditions are most common in the children, and the chronic conditions are more common in the adults, and the duration is more than or longer than 6 months. And you can say it's a kind of the diagnosis of the exclusion. So you can see here in the diagram, it is the CT scan of the abdomen and the pelvis and the chest, actually. But you can see the abdominal part, and you can see this is the part of the liver, and you can also see the spleen. The diameter of the spleen is enlarged, and also, showing a kind of the hypersplenism. In the other conditions, again, that would be chronic leukemias and some kinds of the autoimmune hemolytic anemias, like the hereditary spherocytosis, sickle cell anemia, pernicious anemia, autoimmune hemolytic anemias, and Polycythemia Vera, which is a kind of the myelofibrosis, or you can say a kind of the generalized process of the myelofibrosis, and then thalassemia as well, and erythroblastosis fetalis, and sickle cell disease. This is one another important disease which is responsible for causing the splenomegaly. So, talking about the acute leukemias, we talk about the idiopathic thrombocytopenic purpura, and we know that these purpuras, or they're autoimmune, and sometimes they're responsive to the steroids, and sometimes when they stop responding to the steroid therapy, the only option you're left is with a splenectomy. Then chronic leukemias, and then the hereditary spherocytosis. So talking about hereditary spherocytosis, there's some kind of genetic mutations involving the enchirene or the spectrin proteins, which are actually forming a membrane of the red blood cells. And whenever there's a kind of a mutation to the membrane, then the cells actually there's a kind of the fragility is lost, and that they become very, very fragile. And in case of the hereditary spherocytosis, the normal biconcave shape of the RBCs, they turn into spherocytes, and actually it's because the sodium pump is no more very much effective, and there would be a kind of more of a permeability to the sodium, and there would be more of the sodium coming into the cell, and in turn it causes a swelling of the RBC, making it fragile. And whenever it comes all the way to they try to pass through the splenic pulp, then they are sequestered within the sinusides of the spleen, and they're entrapped, and there is a kind of a destruction. And that is the reason the hereditary spherocytosis, which is a kind of the autosomal recessive trait, results in a splenomegaly. Then some kind of pernicious anemias and autoimmune hemolytic anemias. So all the autoimmune hemolytic anemias in which there is a kind of the massive destruction of the RBCs, they actually all the way come together to the spleen, and they are being sequestered within the splenic sinusides of the splenic pulp, and they're being engulfed, or they're being broken by the spleen, and because of that there is a kind of a splenomegaly. And in one thing to remember in the autoimmune hemolytic anemias is that there would be reti count would be very, very high. So if you are investigating a case of anemia, and you are you're thinking about a chronic condition of the anemia, and you're thinking about the autoimmune hemolytic, always go for the reti count, because if the reti count is increased, then that will give you the indication that it's a kind of autoimmune hemolytic anemia. Another important cause for the development of the splenomegaly is the sickle cell disease, in which the normal hemoglobin A is replaced by the hemoglobin S, which is a sickle cell, and because of that's because of the mutations. And instead of some kind of amino acid change because of genetic mutations, and these because of the change in the amino acid sequence, the hemoglobin, the normal condition or normal shape is started, and sickling of the cells is being generated, and because of that their fragility is increased, and they become more fragile. And again, the process remains the same as in case of the hereditary spherocytosis. Another important cause is Polycythemia Vera and thalassemia, and we actually divide the thalassemia, which is more common in the children, and the thalassemia is a kind of a major thalassemia and a minor thalassemia, which is the thalassemia trait, and there is alpha thalassemia and a beta thalassemia, and there is some kind of amino acid change as well in case of the thalassemic patients. And they also present to you with the splenomegaly, because again there's a lot of destruction of the hemoglobin and RBCs, and altogether they lead to the formation of the splenomegaly. Then sickle cell disease and erythroblastosis fetalis is one of the causes for the splenomegaly. Now, if we talk about the other causes, there can be rickets, there can be amyloid, there can be porphyria, and then now the porphyria is as a kind of a, say a metabolic disorder in which porphyrin is actually the breakdown product of the hemoglobin. But actually, there's some problem with the mobilization. You can see the excretion of the porphyrin, and because of that, the metabolism of the porphyrin is being destructed, and because of that destruction, the porphyrin is accumulated in the body. Okay, so this actually leads to the condition which is called the porphyria, and the porphyrin, this would be excreted in the urine. And if such a urine sample is collected, and that is actually left into the sun exposure for 72 hours, then the color would be changing. It will be because of the metabolism, and the normal yellow color of the urine will be changed into orange color, and that would be a kind of giving you the diagnosis for the porphyria. And porphyria is a kind of a systemic disease. It affects skin as well, and there's a discoloration of the whole of the body. But the acute condition is the one in which there's a nervous involvement of the nervous system, and the patient can actually present to you with a stroke, and that can be the cause of the death. So the metabolic causes would be rickets, amyloid, porphyria, and a Gaucher disease. So the Gaucher disease is one of the glycocerebrospidase deficiency, and there would be a kind of a lipid storage disorder. And because of this, we know that the fats they're being stored in the liver, and they're being stored in the spleen, and because of that, there's a lot of the glycogen storage in the liver and the spleen, and because of that, there would be splenomegaly as well. So again, this is the CT, which is showing you the level of the spleen and the level of the liver, and you can see the hypodense lesions, multiple hypodense lesions present in the spleen, or in the liver as well. It's kind of showing you the diffuse deposition of some kind of the chemical or material, which is the glucocerebrospidase in case of the Gaucher disease. The same can happen in case of the amyloidosis, in which it's also kind of the systemic disease, and there's some problem with the the breakdown of the amyloid, and that beta-plated sheets, they're being deposited in the various organs of the body, involving the brain and the liver and the spleen and the different multiple organs. So that can be one of the metabolic causes, can be one of the cause of the splenomegaly. Now the circulatory causes can be infarct, there can be portal hypertension, because the portal hypertension is actually, it's actually the obstructing the circulation, or obstructing a drainage coming from all the way to the spleen, and because of the obstruction of the portal vein, there would be involvement of the spleen. Okay. So again, you can see this is the level of the CT scan of the abdomen, showing the spleen and the liver, and you can see actually the dilated bile duct, and you can see the dilated portal vein, and these can actually, because of the portal hypertension and the dilatation, there would be a kind of a reactive splenomegaly. The other causes can be a segmental portal hypertension and some kind of the collagen vascular diseases, like the Still disease. It's a kind of autoimmune disease, and it's again a systemic disease involving the multiple organs, or the Fetalis syndrome. And the Fetalis syndrome is a kind of rheumatoid arthritis, which not only involves the arthritis of the different joints, but it's also causing a neutropenia, and it's also causing a splenomegaly. So the Fetalis syndrome can also be one of the cause for the development of this. And this is the MRI and of the sagittal section, and you can see a large, massive spleen, which is actually not only limited to the abdomen, but it's coming all the way to the pelvic cavity as well. So the Fetalis syndrome, you should also keep in mind that it can be one of the causes for the development of the hypersplenism. Now, talking about the some of the conditions which are like very rare, but they are still a cause of hypersplenism as a non-parasitic cyst. And these cysts can be congenital, or they can be quite like the hydatid cyst, and the other simple cyst, which can just like the renal cyst, like the cyst in the liver. There can be multiple cysts in the spleen, and that can cause enlargement of the spleen. The neoplastic conditions, which are actually causing some kind of obstruction to the portal vein of the splenic vessels, or the seeding or the invasion to the spleen. They can be the angiomas, the primary fibrosarcomas, a Hodgkin lymphomas, and some other cause of the other lymphomas. So generally, think about if you are trying to palpate a patient, and the abdominal examination, you find out to have that the patient has got the splenomegaly, then think about all the metabolic causes, the infectious causes, the bacterial causes, correlate everything with each other. If there is a fever, then there would be some kind of infective cause, okay? So try to think about the leishmaniasis or schistosomiasis, if there's a history of travel, and think about the typhoid, think about the malaria, think about the tuberculosis. But if the history is not short or brief, and history is prolonged greater than 6 months, then think about the chronic infective or inflammatory or autoimmune processes, right? And think about this spherocytosis, autoimmune hemolytic anemias, or leukemias and the lymphomas, and always look for the broader picture. Most commonly, what happens is when you are sitting in a surgical OPD and you're trying to investigate such a case which is coming, usually they are diagnosed and they're being referred by the medical specialist, and they come to you for a definitive management. That's obviously the splenectomy. But if you are a GP and you're sitting in that, and a patient comes to you with a splenomegaly, think about all these things, and a definitive management plan would be like in case of the idiopathic thrombocytopenic purpura, you go for obviously the splenectomy. Or usually if you talk about the infective causes, that's a kind of a reactive splenomegaly, right? So in case of the reactive causes, or you can say the bacterial infections, you just give the proper therapy to the patients, okay? Treat the typhoid, treat the leishmaniasis, or treat the tuberculosis, instead of ending up your patient in a splenectomy, because there would be some kind of a post-splenectomy complications, and we'll be talking about this in a couple of minutes. But think about if there is a kind of autoimmune process, especially if we talk about the anemias or leukemia, not actually the leukemias, but actually the it's a kind of in case of the acute leukemias, and there is a relapse again and again, you also think about the splenectomy. But the most common causes like the ITP, thalassemia, hereditary spherocytosis, sickle cell disease, you go for splenectomy, because actually that's the cause of the anemia, because there's a lot of destruction going on within the spleen, and you take out the spleen, and the patient's anemia is relatively, not absolutely, but relatively stable. So talking about, we talk about the hypersplenism, and we talk about the other causes for the splenomegaly. Now, the part which is surgically important is deciding about the splenectomy. We'll be talking about the operative detail as well, but first of all, you should need to identify which patients you are going to take under your scalpel, okay? So for that, think about if there's a kind of traumatic diseases, and if there's a kind of a history of the trauma to the abdomen, and you see a free fluid in the abdomen, and you're thinking about there's a tenderness in the left hypochondrium, and you're thinking about a trauma to the spleen. The spleen has got a rich vascular blood supply, and if you do not do the splenectomy immediately, the patient can go to the hypovolemic shock, and then the patient can ultimately will end up in the death, okay, secondary to the hypovolemic shock. Then obviously the emergency surgery is the splenectomy to save the life of the patient. The other causes, like if you talk about the elective splenectomies, so the elective splenectomies can be, some kind of the tumors involving the spleen or invading to the spleen, or especially in case of the ITP, in case of the hereditary spherocytosis, thalassemia, or sickle cell anemia. So you need to find out the cause for elective or emergency splenectomy. And talking about you need to make some proper pre-op preparation for splenectomy. You need to arrange the blood products, you need to arrange the platelets, the fresh frozen plasma, the cryoprecipitate, because your patient can actually start bleeding massively, and obviously you're taking out the spleen, then and you should there can be thrombocytosis as well. Intraoperatively, so arrange these things and arrange the blood as well that could be needed. So the pre-operative kind of management is also being required. Now, important thing is, if you are done and you're prepared, either it's emergency or elective surgery, you should have whole blood, you should have packed red blood cells, you should have platelets, and you should have fresh frozen plasma, the cryoprecipitate, available to you readily. Okay, you should have a good support system, the anesthesiologist, and the whole bucket of a team to help you in case of the crisis, especially in case of these ITPs. This chronic ITP patient can actually turn into acute crisis, and then you should give the patient steroids immediately, intraoperatively, and all those things. Okay, so talking about the principles for the elective, we're not talking about the emergency splenectomy, but we are just talking about the elective splenectomy. And after you're done with the pre-operative management of that patient, then what you have to do is, some surgeons give a midline incision, and if there's a massive splenomegaly, thoracoabdominal incision can be given, or some can approach through the transverse left subcostal incision. Okay, so the first thing you need to plan is how to make or the incision. Okay, so it can be a vertical midline incision, it can be transverse left subcostal incision, or it can be a thoracoabdominal incision. Okay, so after you're done and you enter into the spleen, then you have to mobilize the spleen, which is very, very much important. Okay, so for the mobilization, what you need to do, you need to enter the gastrosplenic ligament, which is the ligament, a kind of a connection between spleen and the stomach. And we know that actually the gastrosplenic ligament contains the short gastric arteries, and these short gastric arteries actually are the branches of the splenic artery. So actually what happens is, like, you have to enter into the gastrosplenic ligament, and you have to divide and ligate the short gastric vessels. Okay, when you're done with that part, you have to mobilize the splenic flexure, and then you have to go to the posterior surface of the spleen. You have to open up the linear-renal ligament, and you have to divide all the vessels which are coming all the way in your round, the splenic vein and the splenic artery. And then you have to medially rotate the spleen. And after, when the spleen is mobilized and it's being rotated medially, then you will ligate the vessels which are in the hilum of the spleen. Okay, and then you can just, after mobilizing the posterior and the anterior surfaces, you can take out the spleen. Now, another important thing is, sometimes you decide for the partial splenectomy, or you decide for the complete splenectomy. Okay, so sometimes what happens, there's a kind of excessive bleed. So intraoperatively give FFPs and the platelets to your patient and transfuse as much as of the blood possible arranged to you. And then there's a kind of some kind of a packings, which are called as like the spongiostome. So when you take out the spleen, you can leave that spongiostome within the left hypochondrium, so that if there is any kind of a bleeding, that should be absorbed by that material, which is the spongiostome. It's actually a sucks as the blood, and it's as a kind of it's absorbable, and you can leave in the abdominal cavity. Okay, so if we talk about the you know, the procedure. So this is, you can see this is a kind of a left lateral position. And if you're trying to, because since you are approaching you make a kind of a, you are working on the left side, so you need to right lateral position of the patient. So this is actually the right lateral position of the patient, and you give a transverse or midline abdominal incision, and then you go all the way abdominal, layers are being splitted, and you actually mobilize the splenic flexure to get to the spleen. Then you the splenorenal gastrosplenic ligament is being divided, and you get into the short gastric arteries, and you get to try to ligate them. And after that, you also, splenic vein is also being ligated and doubly sutured and clipped so that hemostasis is being secured. Then you try to go to the posterior surface, mobilize the spleen, medially rotated, and at the hilum of reach the hilum of the spleen and tie the splenic artery. Okay, so you can actually see that this is the transverse colon and the splenic flexure, and it's actually a retroperitoneal, and it's on the posterior surface, and these are the ligaments you need to get hold on, or you need to get into these ligaments, and you need to mobilize the spleen, and you can take them out easily and safely. And then you can see that this is the hilum, and you have to clip all these vessels. Okay, the splenic artery, the splenic vein, the short gastric vessels, you have to divide them, and you have to ligate them. And then you have to be very careful, and you can place a drain, or you can do the sponge stone, and then which is a kind of absorbable thing, and you post-operative management is somehow very much important, because sometimes you have to transfuse the platelets, and you have to transfuse the platelets and the RBCs, or a kind of a packed red blood cells to your patient. Then, if we talk about the postoperative complication, the acute complication is a hemorrhage. If there's a slippage of the clipping ligature you put onto the spleen, or you put onto the vessel, there can be a massive hemorrhage, and then you have to re-explore. So think about that. There can be atelectasis, there can be pleural effusion left-sided, there can be injury to the diaphragm as well, and the patient can go to the atelectasis, respiratory failure, and then you have to take care of all these things. Plus, because spleen is actually a part of the reticular endothelial system, a kind of a defense system, and then you have to put your patient on a vaccination. The Neisseria meningitis, the pneumococcal vaccines, and Haemophilus influenza. These important vaccines, they should be given to these patients post-operatively. So you got to be very, very careful taking a decision. Like if you're obviously, if it's a kind of a trauma to your patient, then you go for the emergency splenectomy. In case of other causes like the ITP and other, in which there's a massive splenomegaly or hyperfunctioning of the spleen, and the patient is, symptomatic because of excessive destruction of the cells within the spleen, then you have to end up in elective splenectomy. And always make a good pre-op preparation, prepare the platelets and all the blood products you need. And we talk about a little bit about the operative steps, the incision and the mobilization, the clonic flexure mobilization, and then you have to go into the gastrosplenic and the lienorenal ligament, and you have to go all the way and ligate the vessels, and then you have to take out the spleen. And the post-operative complications, you need to take care of your patient, and you need to give vaccination for four important organisms: the Neisseria meningitis, Haemophilus influenza, Streptococcus pneumoniae. These are important because your patient might end up with these infections, and sometimes you need to put the patient on a steroid therapy as well. So actually the patient bears the stress of condition of the patient in case of the surgery, especially the splenectomy. All the surgery is a kind of a stress to the body, but you talk about the spleen, it's a kind of a big stress, so you need to be very careful post-operatively. So that's all for today. We have been discussing about the different causes for the splenism, hypersplenism, and splenomegaly, and then we talk about the splenectomy, the operative details, and the indications, the elective and the emergency situation. So that's all for today. Thank you for watching sqadia.com.